Yeah, thank you for the kind introduction. So on this first slide, I want to talk about what stents and guidewires are and why imaging them is useful. So stents and guidewires are used in the minimally invasive procedures that are performed in interventional radiology. Examples include the embolization of tumors or the treatment of aneurysms or stenoses. An illustration of such an example is shown on the bottom right in this figure. So the patient has a stenosis, and to treat it, a guide wire is introduced into the patient's vasculature and navigated to the target site. And following that, other tools like catheters or stents are introduced into the patient. And since these interventions are performed percutaneously, some form of image guidance is required. Today, this image guidance is usually provided by X-ray-based 2D fluoroscopy, which means that a sequence of 2D X-ray images is displayed to the surgeon. This modality offers high spatial and temporal resolution, but lacks depth information. An example of such a 2D fluoroscopy sequence can be seen on the bottom left. So you can clearly see the guide wires and the catheter and the stent in this video, but you also see that there's no depth information. So what we imagine is X-ray-based 3D fluoroscopy, which would mean that a sequence of 3D images is reconstructed from a sequence of 2D X-ray images. This would provide full 3D information and of course also high spatial and temporal resolution. A major challenge for realizing X-ray-based 3D fluoroscopy is dose efficiency. So for each 3D reconstruction, one can only use very few X-ray projections to limit the dose that is applied to the patient. On this slide, I want to give an overview over how we imagine a 3D fluoroscopy pipeline could work. So on the left, we see a sequence of X-ray images is acquired continuously, and then the interventional tools and the patient anatomy are reconstructed separately at different temporal rates. So the patient anatomy could be just updated from a prior 3D reconstruction, or we could use the projections that we acquire during the procedure to do new reconstructions using classical CT reconstruction algorithms. And the interventional tools, we want to reconstruct them at a higher temporal rate, for example, 5 volumes per second, using only the latest few X-ray projections. And once we have both reconstructed, we can blend it together and display it to the surgeon. So the topic of this talk will only be this upper part of the pipeline, the reconstruction of tools from few X-ray projections. There's prior work on this reconstruction of tools from few X-ray projections. On the one hand, there are algorithms specializing in the reconstruction of curvilinear structures, like catheters and stents. Here we are more interested in more general tool reconstruction algorithms that can reconstruct other tools as well, like stents, for example. And specifically, we are here building on recent work on the reconstruction of guide wires, stents, and coils from 4 X-ray projections, which and this pipeline I'll show on this slide. This pipeline, by the way, received the Sylvia and Moses Greenfield Award for Best Paper in Medical Physics in 2021. And the pipeline works as follows. So 4 X-ray projections are acquired simultaneously. That's the assumption. And then from each of these X-ray projections, the tools are extracted by applying a neural network called the deep tool extraction. And then these deep tool extraction images are back projected into a volume, of which one transversal slice is shown here. And then a second neural network, the deep tool reconstruction, transforms this back projection volume into a voxel-wise segmentation of the tools. So in this work, we want to improve this pipeline in 3 ways. First, we reduce the number of X-ray projections from 4 to 3. Secondly, we don't back project the 3 projections, the 3 deep tool extraction output images into the same volume, but into 3 separate volumes. I'll refer to this as a 3-channel back projection. It is illustrated here by the different colors. And the third change is that we use a 3D unit instead of a 2.5D unit for the deep tool reconstruction. So a few words on the first part of the pipeline, the deep tool reconstruction, the deep tool extraction. So as I said, the input is an X-ray projection, and the target is in this case the line integral of the attenuation coefficient of the tools contained in the input projection. And we implemented here the deep tool extraction as a unit-like CNN with 7 resolution stages. The training and validation data were generated by combining cone beam CT X-ray projections of patients that didn't contain interventional tools and forward projections of simulated guide wires and stents. In total, we generated the data set from 12,000 forward projections of simulated guide wires and stents, and about 2,700 cone beam CT X-ray projections of patients that came from 9 different 3D scans. As a loss function, we used the mean absolute value. The second part of the pipeline is the deep tool reconstruction, which, as I said, takes this 3-channel back projection volume as input and outputs a voxel-wise segmentation volume. As an architecture, we used a 3D unit-like CNN with 6 resolution stages. Training and validation data were generated or simulated by forward and back projecting simulated guide wires and stents. In total, we generated 40,000 scenes, where each scene consisted of 1 or 2 guide wires and 1 stent. As a loss function, we used the soft dice loss with Laplacian smoothing, and to find out whether this 3-channel back projection is advantageous compared to the 1-channel back projection, we performed training twice with these different kinds of inputs. Regarding the real-time capability of this pipeline, on an NVIDIA RTX 3090, one inference of the deep tool extraction takes 40 milliseconds, and because we have 3 projections, we have to apply it 3 times. The time for the deep tool reconstruction is 260 milliseconds, and yeah, the time for the back projection is negligible compared to those times, so that in total we have 380 milliseconds of inference time, which already allows for 2.6 volumes per second, and there are of course many possibilities to reduce this inference time further. So although the training of the pipeline was performed on simulated data, the results I'm going to show you are on measured data. These data were measured in a stop motion fashion using a flat detector. So that means for each time step, we performed a 3D scan with fine angular sampling. And then between the next 3D scan, we moved the tools, yeah, and then performed the next 3D scan. And then retrospectively from each 3D scan, we chose 3 X-ray projections separated by 60 degrees to simulate yeah, this scan. So for the first time step, we used the projections at 0, 60, and 120 degrees. And for the next time step, we could have used these angles as again, but we chose to choose angles that correspond to a rotation of 19 degrees between the time steps. This is done because we not only want to use these projections to reconstruct the tools, but also to reconstruct the patient background. And there it's useful to have projections from all directions. Yeah, the objects we scanned were an anthropomorphic trunk phantom with a soft tissue equivalent extension, and the tools were placed between the phantom and the extension. we simulated patient motion by translating the whole phantom according to a sinusoidal motion in the superior inferior direction, and by pulling out the guide wire between the time steps. Yeah, in total, we captured 3 scenes this way. The first scene contained 2 guide wires, the second scene 1 stent, and the third scene a guide wire inside a stent. So let's have a look at the results on the first scene. So on the top left, you see one of the 3 X-ray projections that are used as input. And yeah, the other 2 projections are omitted for visual clarity. You can also see that you can see this 19-degree rotation that I was talking about in this projection. And yeah, on the top right, you see the output of the deep tool extraction when applied to the input projection on the left. And on the bottom left, you see the reconstruction, so the output of the deep tool reconstruction as a volume rendering. And if you compare it to the bottom right, which is the ground truth, you can see that these are very similar. This up and down motion of the tools, this is the simulated patient motion that I was talking about. And if you look closely, you can also see that the curved tip guide wire is pulled out of the patient because the distance between the curved tip and the straight tip, it decreases during this sequence. Okay, now let's have a look at the results on the second scene. Here, this scene contained 1 stent, which again does this simulated patient motion. And you can again see that ground truth and reconstruction look very similar. And the third scene is more challenging. Here we have a guide wire inside the stent that starts at the beginning of the sequence. The tip is outside of the stent, but then during the sequence, I pulled the guide wire into the stent further and further. And you can see that even when the guide wire is inside the stent, the tip is still reconstructed well. Okay, we also did a quantitative evaluation. So for each time step of each stop motion measurement, we computed the ground truth by computing a filtered back projection of all projections in the 3D scan, and then threshold segmenting this filtered back projection. And yeah, we did not directly use like the dice coefficient, for example, to compare the ground truth volume and the deep tool reconstruction output, because the diameter of the guide wires and struts in the ground truth volume is uncertain, because it's highly sensitive to the threshold that you use during the generation of the ground truth. So therefore, we compute a metric that is based on the center lines of the tools rather than the tools themselves. So we computed these center lines for the ground truth and the deep tool reconstruction output by using the 3D thinning algorithm of Lee et al. This is also sometimes referred to as a skeletonization. And yeah, then the figure of merit we used is the average distance of the voxels in the center line of the ground truth to the center line of the deep tool reconstruction output. And the values of this metric for the 3 scenes can be seen in the table on the bottom. And yeah, the middle column and the right column, if you compare those, you can see that that giving the 3-channel back projection as input to the deep tool reconstruction is advantageous, because it reduces this the value of this metric. And yeah, in general, we see that for all 3 scenes, we have about 0.3 millimeter average distance between the ground truth and the reconstruction. So to conclude my talk, we presented the reconstruction of guidewires and stents from only 3 X-ray projections. We demonstrated sub-millimeter accuracy on measured data of an anthropomorphic phantom. And yeah, the pipeline is close to real-time capable or real-time capable, depending on how you define this term. With that, I want to thank you and welcome your questions.
Thank you. The paper is now open to questions.
Thanks for the interesting talk. I just have a question. For the reconstructed image volume, are these binary or are you reconstructing gray values as well?
So the target is binary, but the last layer of the deep tool reconstruction is a sigmoid layer. So in principle, it can output any value between 0 and 1. But in practice, we see that the network learns outputs almost always 0 exactly or 1 exactly. There's not much in between. So it's quasi binary, I'd say.
Okay. Okay. Have you tried just using TrueView then, if it's just a binary output?
Yes. So we presented something on the reconstruction of guidewires from TrueViews on the SBIE conference this year, and since then, or also already then, we reconstructed stents from TrueViews. From 2 update views, I should say, and there we use also the 2 views from the previous time step. So we use temporal information there because using just 2 projections and no temporal information, there's too much ambiguity in the position of the tools. So there we found that using this temporal information is necessary.
So excuse me. So if you don't have a motion, for example, simulated in then would you say that TrueView would be enough? Or I don't know if you've tried that.
No, I'd say even if there's no motion, 2 views are not enough. If yeah, these from 2 views, if you have a guide wire that does like a loop like this, if you view it from 2 views, there are basically 2 configurations of the guide wire that are plausible. One rotated by like 90 degrees, and so only 2 views is not sufficient. But we think you can do it with 2 update views. So in each time step you acquire 2 views, but then in the next time step from 2 slightly different views. And if you use all these projections together, then you can resolve these ambiguities.
Thanks.
I have just a question. It's trained on simulated data and it works on phantom data, but still, do you have any idea of what is favorable situation and what is a challenging situation for this to work?
I think a big challenge is noise in the projections. So if you, for example, have a lateral projection in the abdomen or something, then you could have very high noise, and the deep tool extraction can be unable to extract the tools. In fact, if you look at such a projection, you don't see the tool anymore. So then you really need to use some temporal information from previous projections where there was not a lateral projection, but a more favorable with less attenuation.
Thank you. Let's thanks the speaker again.